Good morning. First of all, I want to thank Euretina for inviting me to participate in this session. I am going to present my talk entitled Posterior Staphyloma, a Determining Factor for Myopic Maculopathy. My financial disclosure: axial length has been the most used biomarker in high myopic eyes to determine definition as important as the concept of high myopia, while also contributing in the concept and definition of pathologic myopia. However, I can ask you to allow me to make some clinical observations. In the above picture, you can see 3 highly myopic eyes with large axial length and very good visual acuity. In turn, below, you have 3 highly myopic eyes with identical axial length and very poor visual acuity. What is the difference between one group and the other? Exclusively the presence of posterior staphyloma. Let's move to another clinical observation. The following 2 eyes with the fundus image and OCT, I bet none of you would hesitate to classify this patient as high myopia with posterior staphyloma with wide macular type. However, axial length precludes using the concept of high myopia because these 2 eyes not reach 26 millimeters. Two more samples with 34.74 axial length, 34.25 millimeters with very good visual acuity. In the previous talk, Professor Onomasui has explained perfectly the concept of posterior staphyloma, so we are going to go back to this subject. The goal of this study was to determine the influence of posterior staphyloma on the development and progression of myopic maculopathy. It was a cross-sectional study, non-interventional, that included 467 highly myopic eyes of 246 patients. Patients underwent a complete ophthalmological exam, including multimodal imaging. Presence of posterior staphyloma was defined as the main variable analyzed between 2 groups, posterior staphyloma versus non-posterior staphyloma. Age, axial length, best corrected visual acuity, atrophy, traction, neovascularization components, and presence of severe pathologic myopia. 2 different cohorts were studied, age-matched and AL-matched, comparing posterior staphyloma versus non-posterior staphyloma eyes. This is the complete series of myopic eyes studied with axial length ranging between 26 and 37.60 millimeters. If we compare eyes with posterior staphyloma versus those without it, we find that they are older, longer, with worse visual acuity, and with greater component of atrophy, traction, and neovascularization. Also, the proportion of eyes with severe pathologic myopia was higher. To avert the possible impact of age and axial length on the development of posterior staphyloma, 2 cohorts were made with the same number of patients presenting posterior staphyloma as well as those without posterior staphyloma. This is the age-matched group with 94 eyes per group, in which we find again that eyes with posterior staphyloma are longer with worse visual acuity, and the same for the atrophy, traction, and neovascularization components. There is also a greater number of patients with severe pathologic myopia. This is the AL-matched group with 70 eyes per group, in which we can also observe that eyes with posterior staphyloma are also older with worse visual acuity, and the same for the atrophy and traction components. Also, a greater number of patients with severe pathologic myopia. According to the logistic regression analysis, age and AL were significantly associated with the presence of posterior staphyloma. The main limitation of our study were that determining the presence of absence of posterior staphyloma has not been performed by way of using new accurate imaging methods such as wide-field OCT. Since we don't have the possibility of using this imaging technique, the study was performed by 2 retinal experts combining the examination performed by indirect ophthalmoscopy in addition to the findings of surface OCT and wide fundus photography. Although our study might be underpowered for detecting significant differences after matching by age and L, Both analyses provided interesting information about the impact of the two variables of the development of posterior staphyloma. Axial length in posterior staphyloma types 3, 4, and 5 might not be accurate. For this reason, we have reanalyzed our patient performing 3 groups: the group without posterior staphyloma, the group with macular staphyloma, and the group without macular staphyloma. In comparing these 3 different groups, we find again statistical significant differences and allow us to conclude that macular posterior staphyloma is the principal factor for developing myopic maculopathy with different axial length, with no different age, with worse visual acuity, and more component in the atrophy, traction, and neovascularization. Also, the number of severe pathologic myopia was statistically higher in the macular staphyloma group. In conclusion, we found that macular posterior staphyloma is associated with myopic maculopathy, worse visual acuity, and higher prevalence of severe pathologic myopia. The axial length and age in this order constitute the main factors for the onset of posterior staphyloma. Here is the paper published in the American Journal we have discussed at this moment. Thank you, OIMAL team. Thank you, everybody, for your attention.
Thank you very much for this beautiful presentation, very clear. So we'll go to the discussion. If there is a question here. So I do have a question for you. Do you think that beside the staphyloma, we need also to have some changes on the surface of the retina, having a traction by the vitreous, by a membrane or something to have to have maculopathies or not?
Sure. I think the key is posterior staphyloma. In the higher myopic without posterior staphyloma, the eye is higher, but the surface of the retina is normal. There is a less number of choroidal neovascularization. If the staphyloma develops, traction maculopathy develops in the staphyloma, choroidal neovascularization also, and atrophy also.
And what could be the explanation for the neovascularization if for the same axial length you have one with staphyloma, one with more homogeneous growth? We don't know yet.
It's very, very difficult to say. Probably the changes in the choroidal circulation, but I don't know.
Any opinion or questions?
Thank you for this wonderful talk. So, do you think where the deepest point is in the staphyloma matters where the atrophy and the CNV develops?
No. I think at this moment, no. There is no enough quality of imaging study to do this concept.
Because Kyoka was showing that the deepest point is temporal, but yours often show the deepest point is in around the optic disc.
Yes.
Mm-hmm. Anything can happen, I guess, huh? All right, thank you very much.
Thank you very much.
So the next speaker